Good evening. Today is Wednesday, August 6th, I believe. It doesn't matter. 2025. I'm making this video to let some people know where I stand. This is not going out publicly, just to certain people where I stand with all my visits and appointments. I think both the radiologist and oncologist presented a fairly optimistic view that it wasn't as you know immediate life threatening as it kind of the results read. To remind you, there's cancer in my thoracic and lumbar regions. I was treating that, not knowing it was cancer, with pain injections. That doctor has since paused care. And I'm currently attempting to transfer care to MD Anderson. Me and Audrey kind of felt that it would be smart to just get things started while that transition occurred, which is fine with me. My oncologist mentioned several medications like Lupron and things like that. Lupron is a estrogen eliminator. I really it has a lot of side effects. I don't see, it's probably maybe a little bit more powerful. We would be getting rid of the tamoxifen, I think, which is an estrogen blocker. But her main focus was to have me go back on Verzenio. Verzenio is going to have not an immediate effect, if any effect at all. I was on that for 2 years. I don't really remember the differences. Everything seems to just blend together. But to go back on the Verzenio, the cost is not, I won't be paying for it, but it's $15,000 a month. A CDK4/6 inhibitor, which is kind of like the treatment. That's the in thing now. For me, I researched that drug pretty extensively, and there's been nothing new over the last 2 or 3 years. I do know that in Denmark Health Ministry, who authorizes care, they have universal health care there. That was on their prohibited list along with another one, and it's probably due to cost, but they did some research of their own and they found zero benefit to the medication. So what will follow is that gentleman talking for 3 or 4 minutes about what they found. Eli Lilly, who produces the drug, in response sued them in court and won, and that's the end of the story. Basically, they were requesting that Denmark produce more abundant researched data. I think they had, 1,500 participants wasn't enough, but really that's outside the scope of even a country to be doing research studies like that. For what? So that's why I'm on the fence of what to do, actually. So I'll have to think it over. I have other things going on. I'm very tired. I take medication for that. I'm still very tired. Other than that, I'm pretty fine, and a lot of I would say, low pain all throughout due to arthritis and the condition. Following this is just that video. It's 3 minutes by a European doctor talking about why they made that decision. And then, of course, I'll throw in the press headline of Eli Lilly's victory. But, here's the main concern out of everything. Sorry to be jumping all over it, but that's why I'm recording. It'd be worse in person. If I went back on this Verzenio track, there's an 8-week window where we're seeing if it doesn't work, relying on that DNA test in Signatera, which is looks at disease burden response rates. So it could be no response, it could be a great response, or it could be in between. But my concern is really just waiting for the 8 weeks on test results when the serum levels in the Verzenio are going to take at least I'm making that word up, but that's what I believe it is. At least 2 to 3 weeks to get into any therapeutic range. It's just like oral chemo, you know. So that's all. That's all I have. The information I have. Audrey has more, but it's, again, the stuff presented to me was, we have drugs that may work, but you'll have a lot more side effects. And it's, you know, I'm definitely going to do something. This is not a, something will be done medically. I'm not at that point. And especially now is when you're going to do it. I wouldn't wait, say, like 3 months or 6 months. It's now, because as far as we know, it's sort of in treatable ranges. So, just as a side note, radiation isn't indicated. It's only if the cancer is interfering with certain types of functions, you know, like my movement or something. And that's it. I appreciate you listening, but please do just hang. It will come right after I stop speaking. Hang on to the. Just check out that video so you can see how I'm kind of conflicted. I know there's a motivation by that doctor because he does run a universal health care, and they have to consider costs. But if it truly was like a blockbuster cancer breaker type thing, they're not gonna go after that drug to save money. And that's all. And I'll probably in the next 2 or 3 days figure things out. I have the paperwork and things I need to do in terms of like Social Security and things like that, and just that I need to get done, and return phone calls. I don't really just don't have the energy to speak on the phone over and over again about the same stuff. So love you. I will follow you up with a video. Thanks.
CDK4/6 inhibitors have demonstrated important improvements for women with ER-positive, HER2-negative breast cancer. First, we had second-line studies, then we had first-line studies, but never a comparison between both. Nevertheless, a first-line strategy was adopted by most guidelines as the preferred strategy. These agents, however, have toxicity, considerable costs, and there are mechanisms of resistance occurring when you have combination therapy. Therefore, also inspired by ESMO's and ESCO's commitment to stimulate equitable and sustainable healthcare, we set up the SONIA trial to have a one-to-one comparison between a first-line strategy and a second-line strategy. All patients were randomized one-to-one for either of those strategies in a backbone endocrine therapy, which was similar for all patients. So they got an aromatase inhibitor in first line and fulvestrant in second line. Primary endpoint was progression-free survival after 2 lines of therapy. I can continue if you want, I just talk on. Yes. 1,050 patients were randomized. Response was measured locally according to RECIST 1.1. And key secondary endpoints were overall survival and quality of life. At the data cutoff, December 1st, 2022, we had sufficient events, PFS2 events, to do the primary analysis. What we saw was first a confirmation that in first-line treatment, CDK4/6 inhibitors prolong progression-free survival. However, if all patients cross over to a second line, the benefit disappears, and progression-free survival after 2 lines of therapy almost overlap. The hazard ratio for our primary endpoint was 0.87 and not statistically significant. Overall survival was also measured at 35% data maturity, and the hazard ratio was 0.98, p-value of 0.83. Importantly, however, toxicity was increased in the first-line use owing to the fact that you have a longer duration of treatment by almost 16.5 months. We also measured quality of life according to validated questionnaires, FACT-B, EQ-5D, at several time points along the study. There was no difference in quality of life between the arms. So we conclude that as a first-line strategy does not give a better progression-free survival, it does not give a better overall survival, and it does not improve your quality of life. However, toxicity is increased, quality of life is not better, and the costs are dramatically higher at $200,000 per patient. So we think that the SONIA results seriously challenge the paradigm that first-line use is the standard. And we think that endocrine single agent in patients with metastatic ER-positive, HER2-negative breast cancer is an excellent option. Of course, we'd like to see which patient benefits most from either strategy, and biomarkers should be able to tell us. Until now, however, biomarker search in the CDK4/6 space has been rather disappointing, and we have to make patient decisions today. Again, the SONIA results favor a second-line strategy with CDK4/6 inhibitors.